I want you to imagine for a minute that you're in the middle of moving houses. It could be a big move across the country, or it could be a move just across town. The moving van is tightly packed. The kids, they're waving goodbye to what was once their home. And you are in the front seat thinking through all those things you have to do to get everyone settled in your new community. Forward your mail. Ooh, easy, quick online form. Check your address on your license. A pain, but not that bad. Get the kids signed up for the school in their new zone. You fill out a form online and you wait for their welcome package to arrive. A new family doctor? You call around. No one is taking new patients. The wait list? Years long. The solution? Waiting around, and while you do, you seek medical care from walk-in clinics and hospitals. That's gonna suck. Now, each one of these tasks are touch points you make with federal or provincial mandated services. And I'm not saying all of them are easy to access, but there's little to no lag between letting the government know you've moved and getting access to new services, except when it comes to primary care. But what if landing a spot on the roster of a new family doctor was more like the process of registering the kids for a new school? Guaranteed access, somewhat seamless, and a given simply based on where you've moved to. Welcome to Primary Focus, a launching point for a national conversation we really need to have about the current primary care crisis in Canada and how we're going to solve it. I'm Dr. Tara Kieran, a family doctor, researcher, and advocate for a better primary care system in this country. I believe in creating a primary care system that's inclusive, comprehensive, and that truly works for everyone. But to do that, we're going to have to make primary care our primary focus. Today on the show, Dr. Rita McCracken. In 2023, Rita published a paper that asked the question, does the way public schools are organized hold answers to solving our current primary care crisis? Rita and I talk about how that analogy could help unlock a paradigm shift in Canadian medicine, and whether this possible solution matches what doctors say they want and need. Dr. McCracken is a family doctor and an assistant professor in the Department of Family Practice at UBC. She studies the family doctor shortage in Canada and structures and interventions that can increase equitable patient access to high-quality, longitudinal primary care. Fun fact, she also spent 10 years working in human resources for tech companies before she chose medicine as a second career. So please welcome Dr. Rita McCracken to Primary Focus. I wonder, can you just actually build this analogy for me? So state the argument, like why is it that primary care should be like the public school system? What is it behind that?
Okay. And I will just preface everything by saying that I know that the education system is not perfect. I have little beings in my life that are in the school system right now. So I know it's not perfect, but let's just talk about how it mostly functions right now. So across Canada, you have communities where folks live and there is a school. In some rural communities, there's sometimes a little bit of a distance, but even in rural communities, there's always a rationale attached to how far is reasonable for a 5-year-old to have to travel for a kindergarten class. And so you see within a community that all levels, the citizens who are living there, the municipal governments, the provincial governments, and the federal governments have acknowledged we need to make sure that this essential service is close and available to this family. And we have that service available. And furthermore, we need to make sure that the services that the kids need are within that school. So if there are, for example, kids who have extra problems with reading, or there is a new curriculum area that the teachers don't have experience about, we're not going to expect those kids to, go with a piece of paper on the public bus for an hour to go and get that extra education and that extra. We bring that resource in to that school, so that we can make sure that there is a standard of education that everybody within that school is getting. And again, there is some really important conversations to be had about rural versus urban education resources, that kind of thing. One of my kids went to an extremely tiny elementary school where there was no librarian, there was no gym teacher. It was just the teacher would be that person. Everybody in the community went to that school. And now she goes to a much larger high school that has so many resources, like so many incredible classes and that kind of thing. So there's all of these differences within there, but we have acknowledged as Canadians, this is what we think is reasonable to expect for access and for services for public education. And it just blows my mind that we're not having that same conversation about what is reasonable access and a reasonable level of services that folks can have for access to primary care when it is so essential. It is absolutely essential to the health of individuals, the health of populations, and managing costs for providing healthcare all across Canada.
What I'm hearing you say is that we need to recognize and acknowledge that access to healthcare, and particularly primary care, the front door of healthcare, is also and should also be a right. And so I think part of the analogy is this building this idea that, we can guarantee access when something is a right. And look, we've been able to do it already. But I know you've taken the analogy even further to think through even, what does it mean in terms of the actual provision of that right? Like we don't make teachers go build their own schools.
Exactly. Yeah.
So tell me a bit about that infrastructure part.
Right. Yeah. So, it would be preposterous for us to think about, kids can't find spots in elementary schools. So let's just graduate a whole bunch more teachers, hire them from the US, and then they will, on their own, come up with this idea of let's figure out which community is most in need of elementary school access. And I'm going to build a school and I'm going to hire all the right people that those kids are going to need. And I'm going to very happily use a portion of the wages that are given to me to pay for the IT infrastructure, the utility services. And I'm going to respond to the fluctuations in the real estate market, which in Toronto and Vancouver is ridiculous. So that's what we're asking family doctors to do right now. And without really even thinking for a second, why would a rational human being graduate from a very arduous professional degree, very often with, I think the median debt is now at $250,000 that you have after you finish your residency program, then let me become this perfect altruistic person who has a comprehensive understanding of municipal politics and economics, and I can set up a business that is going to be the perfect service provision. We have this whole huge meso level of primary care infrastructure that has been magical thinking for decades. And for the love of God, we need to stop the magical thinking. We need to acknowledge that even though family doctors are amazing, incredible people, they are not saints, they are not heroes, they are normal folks who want to be able to work a reasonable number of hours a week, have meaningful work, get paid a wage that seems attractive to them, be able to take a vacation, have colleagues that they work with that support them and that help them meet the vision that they have set for the service that they are providing. And that's what most people living in Canada want from their job. They don't want to be this savior with this omniscience about what the community needs.
The other part of what you're talking about is this idea that doctors are going to school to learn to become a doctor, and then they graduate, knowing how to be a family doctor, but not necessarily a business owner and all of the things that relate to owning a business, managing HR and leases and IT and all that stuff. But we're expecting them to do that. And we're also kind of expecting them to take some of their income to kind of create that infrastructure.
Yeah.
And I think that's where it sounds like what we're hearing is that's a real pain point for new graduates, and it's a pain point for existing graduates. But actually, you've done some research as well, surveying doctors about reforms and what it is that they want. How does what they want, I think, kind of align with this analogy that we're talking about in terms of this public school system? What did you find in this survey? And maybe just to contextualize it, when did you even do this survey?
So I was the assistant head of the Department of Family Practice for Providence Healthcare, which is a large health authority in the Lower Mainland in British Columbia. And this was where I would often get invited to these meetings and hear the explanations of how family doctors were wrecking the healthcare system. And I started just kind of informally asking them, so what do you feel like you need in order to be able to do this job? And so in the 2016 cycle, we took those questions and we made it into a research project. The results were so interesting. For the 2018 reappointment cycle, we had the opportunity to go to a much larger group of family doctors. This was of about 1,100 family doctors who were reappointed. So we said to them, do you want more money for overhead to be able to hire your own team? And then we also asked, would you rather be an employee? So we tried to make discrete choices that were on either side of those concepts. And basically what we found was most of them said, oh man, I don't want to be a business owner. I'd rather have more of an employment environment. And I would like to have a steady monthly pay that I can rely on. And I would like to work in a team, and I would like to be able to take a vacation, and I would like to have predictable sick leave benefits as well. So the majority answers on those things. And again, so it's not rocket science, right? It's kind of basic, like what's the employment environment that we need to attract the family doctors that we want to have? That was very new. That kind of survey had not been done before.
Just going back to this public school analogy, I think the other thing that is striking as well is that when teachers are in a school, of course, somebody has decided where that school is. Somebody has made the infrastructure and is doing the hiring and all of that. But teachers are also there not working necessarily alone, that there are other teachers in the same building. For example, if they're away, that there's going to be someone that's going to cross cover for them. And so there's these elements of teamwork, I think, in the way that a school is set up that sometimes are absent from some of our family practice models. And I wonder if you could speak a little bit more to that as well.
Yeah. I mean, especially, so here in BC, it's where I have my most in-depth knowledge of the structures. The vast majority, I don't have, from the last 2 years, I don't have a measure, but I would say probably at least 80% of family practice offices consist of physicians and medical office assistants. And the physicians, while they may share a physical space, there's very rarely a sharing of professional and care responsibilities. So, for example, you can't book with one of my colleagues unless I have set up a very special situation, even if I'm not there that day, and even if the person has an empty spot. And that is that, each physician is assigned a panel. Our current remuneration system in British Columbia is that if my person who's on my panel sees somebody else too many times, I don't get paid a bonus code 4 times a year. And so there's this, consequence of the panel making of patients. There's been some attempts to kind of address that. But yeah, so we have this main structure, which is physician as independent provider of all healthcare services in the primary care world, to this panel of patients supported by, incredibly amazing, fabulous office assistants. But those aren't medically trained folks. They are managerial and administrative people who nothing would work without them. So, for example, they can't triage folks when they call in. So they can't ask them questions about their symptoms and determine this person needs to be seen today. It's instead, the squeaky wheel gets the grease kind of thing of, if someone calls 5 times, they're more likely to come and knock on my door than to be able to say, this is the triage system. So there are other setups where you would have somebody like I think about, the tiny little school at the end of my block where my daughter went for the first 6 years of her life. The incredibly amazing secretary who was a retired teacher who had decided she was just going to be a secretary in her, this woman, she knew stuff. She could just kind of sense, when you walked in the office, she would ask all the right questions and your problem would be 3/4 solved by the time that she had defined what your problem was. And then would be able to say, okay, here, let's get you to talk to the vice principal. Let's get you to talk to the seat, or here's a pamphlet that I'm going to give you. Go home, think about it. So those kinds of team members who are providing direct care and primary care services are really difficult to access in a team-based environment in British Columbia. I know some other provinces have more established setups. Here in BC, we have 36 community health centers that are, it's quite a heterogeneous group of clinics. They don't all offer the same services, but they do really come from that place of, we represent the community. The community says they need these needs, and we're going to figure out how do we hire all the people that we need. It's probably going to include some family doctors and nurse practitioners, but it may also include social workers. It might include peer supports for substance use, might include immigration and citizenship, legal expertise. So, we've got these very important, highly functional structures that are offering more of a public education school type of service, but the vast majority of services are offered as physician and medical office assistant.
Yeah, it's really interesting because I work in Ontario, and I think the landscape in Ontario and in Quebec and a few other provinces is different than that, where it's, we do have more teams, doctors working with other health professionals. But I think what you're saying is in British Columbia, the vast majority of doctors aren't working in team-based environments. Most of them, if my understanding, up until recently had been working fee-for-service. They might be working with other colleagues, but the colleagues don't necessarily cover each other. And so, this idea of team-based care is something, we're going to be speaking a lot about. It's something that I think we heard from patients in the public they endorse because they recognize we don't have the workforce to enable every person to have a family doctor in that kind of model you just described. What was also interesting is, when we did these conversations across Canada, we heard, particularly actually in Ontario quite clearly that they wanted to move this primary care system more to a public school analogy. And, they talked about this idea. They said that, to ensure that every Ontario has a primary care home, the government should move towards automatic rostering similar to the public school system. They said health teams should be mandated to accept any patient from their catchment area, but at the same time, it was important to maintain an element of patient choice. And then they went on to list kind of how that choice should be operationalized. So, for example, that there was some choice around the provider within that team that they could meet with, that if they moved, maybe that they weren't forced to change if they really didn't want to, that they could opt or find another team without a penalty if in particular it wasn't meeting, their gender, language, or sociocultural preferences. So they had some really thoughtful pieces, but it was interesting to me that, when they had time to reflect, to them, this idea of automatically being guaranteed access was really resonant.
Yeah, I think I've had the opportunity recently to read some of the work of Dean Spade, who's a legal scholar from the University of Washington, Seattle. He presents this idea of thick versus thin relationships, and it really has been hitting me in the head with regards to primary care. And I think what you were just describing about what the Our Care panel in Ontario said that they want to have is they're describing very thick relationships with primary care. So you've got a clinic where you've got all the people and you've got a team that looks after you. You have protection in those multi-layers of those relationships. Whereas in British Columbia, in the average family practice, if your family doctor gets sick, you no longer have access to primary care. It's a very thin relationship that exists between patients and primary care, as opposed to if the patient was attached to the clinic and I got sick, the clinic could figure out how are we going to make sure that this person gets their primary care needs attended to. And a clinic could build the services so that, for example, maybe there's a long-term locum that is attached to the clinic who, in large clinics like mine, we just assume that, life happens. Your kid's going to be sick. A doctor's going to need to miss a day, or there's going to be a ridiculous cold and flu season like we had here this year. And the number of sick babies is going to skyrocket, and the need for appointments is going to fluctuate. So you put that responsibility onto the clinic to maintain those relationships. And then the patient's obligation is only to show up to the clinic, not to have to now be like, oh man, what am I going to do? My doctor had the audacity to get sick and die, and now I am unattached.
You've described one of the reasons why it's so important for teams to be there so that they can cross-cover one another and provide that reliable level of access to everyone. And we talk a lot about teams being composed of a doctor and other health professionals. But in my experience, I think what we're also talking about is that actually teams involve, and I think this is actually the most basic layer, they involve doctors working together in functional groups, cross-covering for each other, so that if I'm away, there is another doctor who's able to provide that level of expertise. And I know, I work in a team like that, where I know if I'm not there, my patients who are very sick would be seen by one of my colleagues. And it gives me so much relief to know, okay, I don't have to feel guilty about being on vacation because my patients are getting the care that I know they need. Hey, it's Tara. I just wanted to pop in with a quick opportunity for you to have your voice heard. Something you hear me talk a lot about on this podcast is the Our Care Standard, a clear outline of what every person in Canada should be able to expect from the primary care system. Now, the standard was shaped by feedback we received from nearly 10,000 people in Canada back in 2022. And now, we want to hear from you. Whether you have a family doctor or not, we want to know, how does your healthcare stack up to the Our Care Standard? It only takes 10 to 15 minutes to share your story. It's completely confidential, and it'll help researchers like me understand what's needed for a stronger, more equitable healthcare system in Canada. And more importantly, it will help us all hold our governments to account to deliver the system we all want and deserve. You can take our survey anytime between now and July 9th. Just head to ourcare.ca/survey or click the link in the show notes of the episode. The Our Care Survey is a research study led by me, Dr. Tara Kiran, at the MAP Centre for Urban Health Solutions at St. Michael's Hospital in partnership with the Canadian Medical Association. All right, back to the episode. We talked a bit about the setup in BC, and I think one of the most striking things in Our Care that we found was just the incredible variation in access to primary care by province and territory. And so, we found that across the country, it was more than 1 in 5 people who didn't have a family doctor or nurse practitioner they could see regularly. But in BC, it was actually more than 1 in 4 people. So it was worse on average in BC, the access, than it was in the rest of the province. And I'm curious if you have any theories on why access to BC was worse than the national average.
Yeah, there's been kind of a few blips in BC recently. One of the things that was happening in 2022 and for several years beforehand was that we'd had a refresh of the payment system in 2003 in BC for family doctors that had been very important. There was a stop work event that had happened in BC for doctors and a government response. There was some renewed energy for primary care, and that was really waning. There had been a few new fee codes that had been introduced, but kind of with limited benefit. And what we saw from the research by Ruth Laverne and Kim McGrail and Lindsay Hedden was that the folks who were doing the work, those new fee codes really reinforced the work, but it wasn't drawing new people in. And those folks were actually using that bump in income that they got to see fewer patients. And so we saw more and more people not having access to primary care and more family doctors choosing alternatives for making an income. Those alternatives included walk-in clinics. It included working in hospitals. It included focused practice elements like addictions care, hospice, long-term care, hospitalist, those kinds of really important roles that are absolutely real and require expertise within our healthcare system, but provided a more attractive work environment. So, and then we saw the pandemic, and the pandemic was a great stressor for, the world, the planet, and in particular, a lot of family doctors. So you can imagine that if you had a setup where you were working all alone before the pandemic and you didn't have a team that was supporting you, and then you had all the stressors of the pandemic, both as a physician and as a parent and as a person living in society. So we saw a lot of practices closing. We don't have good documentation on that. It's very difficult in our administrative data to be able to keep counts of those kinds of things, but that certainly was the story that we were hearing. So you do the Our Care survey in 2022, and it's a disaster in BC. It's an utter and complete disaster. Now, since then, we have had the introduction of the new payment model, the LFP, or longitudinal family practice payment model, which interestingly drew folks who were doing the other work. We've seen mass closure of walk-in clinics in BC, which has actually been raised as a concern now. What are we going to do without the walk-in clinics? You know, there's always this push and pull every time we implement a policy, and intended versus unintended consequences are really important for us to understand. And the good job for the researchers to keep track of those sorts of things.
From what I'm hearing you say is that for many years, basically there was not much change in family doctor income. And then, it was increasingly unattractive for lots of different reasons, including no team, feeling alone. And then the pandemic came, it got a lot worse. That was sort of one of the nadirs of, I guess, access. And that was at the time when we did the Our Care survey. But then at the same time, around then, there was this new introduction of a new payment model. And that's actually changed behavior with more people going back into family medicine longitudinally.
Yes.
But then it's having some consequences. And, I would say, it's a good thing probably that people are moving from walk-in clinics to providing ongoing care. Of course, though, it does pose a challenge for people who still don't have a doctor because they need to get their care from somewhere. And I think this is where some of the tension lies. But I'm curious, do you think that this new funding model has actually changed things for patients? Do more of them have a family doctor now than they did before this funding model?
I don't know. I'm like,
Okay.
I hope so. I really hope so. I'm involved with a project led by Dr. Lindsay Hedden at SFU. We're just about to start analyzing the data to be able to figure out, is that actually real? The PR announcements are, yes, we've got 1,000 new family doctors. And all of us are like, what?
Yeah. Okay. So as we wrap up, Rita, I do want to ask you, what is it that you would like to see happen in BC? If you were envisioning this future and it was going to be bright for primary care, what would you like to see happen?
Well, I think first of all, I want to say that I am in awe of many of my colleagues who are providing high quality, incredible primary care in structures that have been around since the 1980s, which is sort of where primary care was organized in BC. And I want to acknowledge that they do very good work, that they have developed work habits and structures that work for them and work for their patients. And I am not suggesting that we should blow that up. But we do have up to potentially 1 million folks who don't have access to primary care. And we have probably 50 to 60% of new graduates of family medicine saying they want to work in a different way. And so what I want to see in British Columbia is that we start offering a meaningful, structured way for primary care to be organized and delivered in a different way. It could be using the community health center model, or it could be done in a model like we see in the Netherlands, where funding is offered to groups of physicians, but with very strict expectations around what time are you open? How do you handle after hours calls? Those kinds of things. And I think that is where we need to be moving to next. We need to stop with the fiddling of the 1980s system, keep it supported for those folks who are still doing that work and who are going to continue to do that work until they retire. But we're not seeing people jumping into that old model. And we need to be providing an alternative that is different than the boutique model that is being offered, or other less than models like virtual only care or urgent care only. These are things that are not going to be providing the benefits of primary care that we know come to the individual, the population, and to government costs. We need to be having a meaningful alternative for those. Just to, bring this back to the school analogy, I think what we're missing in BC with this new payment model is an agreement about what each clinic is going to offer, what is going to be a reasonable baseline that you can expect that your family doctor is going to do. Like, what are the hours that you can expect that the clinic is going to be open? What are the days that you can book an appointment? The process for booking an appointment, both for a severe, I've got a fever, I'm freaking out, do I need antibiotics appointment versus a well woman check for planning for mammogram screening or that kind of thing that can, take place in weeks to months ahead of time. So we don't have these basic understandings of, you're open these number of hours. This is how you book the appointment. This is how long would be reasonable for you to wait. These are the basket of services that you can expect from your family doctor's office. And this is when you would need to be referred. And this is the process that you would need to get. We're missing that right now. We're missing that common understanding of what is reasonable to expect, like we have for the schools, where that if a kid shows up that, Monday to Friday, except for the many, many days of the year when school doesn't happen. But it's available as a calendar. Like, you have that calendar 2 years ahead of time as a parent to be able to clear expectations. Yeah.
There's clear expectations around access, both from, what is it the teacher should be providing in the school, and also what the parent can expect and should, show up for from a child perspective. I mean, it's interesting what you just relayed in terms of these lack of kind of expectations. We don't have ways in which we have set up our clinics to provide the right care at the right time for people, actually, and that can be a challenge, because it actually contrasts a lot with, our next episode is going to be on the Netherlands, and it is actually a system where doctors are self-employed and they own their clinics, but they have some of these things that you just spoke about. They have standards around accessibility in terms of how long they should be waiting for something that's urgent. They have people who actually help to triage patients who call in to say, how long is it that is reasonable for you to wait given your condition? So there's just a lot more of that kind of standardization, I would say, across the different clinics, and an expectation in terms of what is it that the doctor should be bringing and how should the clinic be organized. And then, what is it as a member of the public or as a patient you can expect in your team. So yeah, it was really interesting hearing you say that. Thank you so much, Rita, for joining us today for Primary Focus and helping us build out that public school analogy, and also helping us understand what primary care looks like in BC and kind of that history and evolution of it. Our listeners are from across the country, so I know that would be really interesting to many who don't have a foothold in the province.
Yeah, no, it's my pleasure. It was really a great opportunity. And thank you so much for creating this airwave space for discussing primary care on a much bigger level.
Primary Focus was created by me, Dr. Tara Kiran, and is made possible by a grant from the St. Michael's Foundation. Miriam Dinesh is our research assistant, Seema Marwaha and Emily Holton are creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. Views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.